Hello again, everyone. I hope you're all doing well. Thank you so much for joining us for our June coffee chat. The topic for today is exploring opportunities to disseminate evidence-based clinical practices for promoting healthy child weight. My name is Molly Garrone, and I'm a Senior Communications Coordinator for the Prevention Research Center on Nutrition and Physical Activity at the Harvard T.H. Chan School of Public Health. And as always, it's my pleasure to be facilitating today's event. First, I would just like to acknowledge our funders who make this work possible. Our choices, work, and events are only for research and educational purposes. The purpose of today's coffee chat is to provide information, tools, and resources to inform and educate. We are not looking to influence any specific legislation. I would also like to note that myself and our guest speaker today are sharing personal perspectives, and we do not speak on behalf of Harvard. So for today, we will start by hearing a presentation from our guest speaker, and then we will move into some Q&A. Today's coffee chat is going to feature an overview of the Healthy Weight Clinic program for children and adolescents, including a discussion of implementation success stories throughout the US, as well as tools and resources available through the program. I'm really excited to introduce our guest speaker for today, Dr. Lauren Fiechtner. Dr. Fiechtner is an associate professor of pediatrics at Harvard Medical School. She is a board-certified pediatrician, pediatric gastroenterologist and nutrition physician, a clinical epidemiologist, and an obesity and food insecurity researcher. She's the director of the Center for Feeding and Nutrition at Mass General Brigham for Children, a large multidisciplinary clinical team which seeks to provide family-centered care to improve children's growth and nutrition. She also serves as a senior health and research advisor at the Greater Boston Food Bank. Dr. Fiechtner has extensive expertise in epidemiologic investigations, neighborhood food environments, social determinants of health, health services research, implementation science, and direction of randomized controlled trials. She has helped lead several randomized controlled trials to treat childhood obesity in clinic and community settings, and through that work has developed one of only 6 family healthy weight programs recognized by the CDC. In addition, her work with the Greater Boston Food Bank has informed programmatic and policy work to improve food and nutrition equity in the Commonwealth of Massachusetts. So at this time, I'm going to turn it over to you, Lauren, for your presentation.
Great. It's so great to see all of you in the audience. I'm a Midwesterner, so I'm glad to see so many people from the Midwest, and also some people local here in Boston. But it's been my pleasure to work on this for the last 12 years and moving my science from really testing and piloting to national dissemination. So excited to talk through this more. You can advance the slide. So I have no financial relationships to disclose, but I just want to thank all my funders, particularly the CDC, who's really made this happen over 3 grant mechanisms, which just ended. Go to the next slide. So most of you know there's 14.1 million children and adolescents in the United States that are affected by obesity. And so we've been really working with colleagues at the CDC and AEP to spread these family healthy weight programs across the country. And they've done a remarkable job of trying to do that and bolster these. But for my story, I really wanted to address how to do this in primary care and provide evidence-based treatment for the 14.1 million children across the country. We can go to the next slide. So in January of 2023, the first clinical practice guidelines from the American Academy of Pediatrics came out for childhood obesity. And from the previous, actually, they weren't complete clinical practice guidelines. They were more of a kind of the expert advice was to offer treatment early and immediately. There's no benefit to watchful waiting. And we know from my research too, that the earlier we offer these programs to children, the better they respond and the lifelong health benefits are there. We should be treating obesity and other conditions concurrently. In fact, we have an open trial right now treating asthma and obesity together, which has been exciting to see that there's impacts actually on asthma in these programs as well. And then there are multiple evidence-based strategies that can be used to collectively deliver this intensive behavioral lifestyle treatment, or the family healthy weight programs from the CDC. And the structured supervised weight management interventions really decrease current and future eating disorder symptoms, which we've shown in our program as well. And go to the next slide. So what is an intensive health, behavioral, and lifestyle treatment program, or which is one of these family healthy weight programs, is that over 6 years in age, you also can go from 2 to 5 with children with overweight or obesity to these intensive health, behavioral, and lifestyle treatments. And they are more effective with greater contact hours. And the most effective treatment option includes offering 26 or more hours of face-to-face family-based multi-component treatment over a 3 to 12 month period. And I don't know that I would, if someone said to me, your child needs 26 hours of treatment, that's a lot. But this is based on the USPSTF guidance, where they looked at all the trials. And basically, once you met the 26-hour contact offering, those children did have BMI decrease, where those that were less didn't necessarily meet that criteria. And so that's why this 26 contact hours. We can go to the next slide. So, our journey has been with the Healthy Weight Clinic, which started about 12 years ago, and now is a CDC recognized family healthy weight program that is brought to national health centers by the American Academy of Pediatrics, and also by MGH. So we can go to the next slide. It's, as we've mentioned many times, is a family healthy weight program. We're delivering this intense health, behavioral, lifestyle treatment, and we are giving it to children with overweight or obesity. It's consistent with our AAP clinical practice guidelines, and it's been proven effective in reducing BMI in actually now a randomized control trial and a dissemination and implementation trial. We've delivered it in clinical settings and primary or tertiary care. It's appropriate for children 2 to 18 with a BMI over the 85th percentile, and it's comprised of group visits and individual visits with a multidisciplinary team of a community health worker, pediatrician, and dietitian. And we did our dissemination and implementation trial in the thick of COVID, and so we have done this virtually, over the phone, in person, all which ways. And shown it to be effective. We can go to the next slide. So this is the participants' view of how they engage with the Healthy Weight Clinic. So they go to their pediatrician and they have a weight and height taken, and then the pediatricians will be notified that this child has an elevated BMI and talk to the family if they're interested in participating in the program. We've co-located these in all primary care practices and have trained pediatricians, because we know to reach 14.1 million children, that's really where we need to go. And primarily we designed it for federally qualified health centers initially. So they get individual clinic visits with their primary care provider, and dietitian, and a community health worker. And those are happening once a month throughout actually the entire 12 months. But then there's group sessions with other families, which in our research and our qualitative interviews, that's what the families wanted. They wanted to learn from other families in a structured way, strategies and proving lifestyle behaviors. And so there are 6 group topics, which I'll show you in a future slide. And those happen once a month in the first 6 months. And then if people can continue to do that, which they do, but theoretically they would be done in the first 6 months. They also get these telephone check-ins from the community health worker, which is incredibly important. If they've missed a visit, or they didn't get to go to the group session, we can send them short videos or talk about the core components of those group topics that they might have missed. It also is a chance for the community health worker to check in on their goals, make sure they have the resources available to them to meet their healthy goals. So if we are working on healthy eating and the family has food insecurity, we want to make sure they're enrolled in SNAP and WIC if they're eligible, and also know about local free groceries at food banks or food pantries that could be beneficial to them. There's also an optional text messaging component to this where families get 2 texts per week that just promote healthy living, and also sends them short videos of the core topics, and also community resources in their neighborhood or larger community. And then the last 6 months is sort of more the maintenance phase. So they're having the individual visits with their team, so the community health worker, pediatrician, and dietitian, and then they're having still telephone check-ins with the community health worker and the text messaging. And that's how we get to our 26 contact hours. We can go to the next slide. So as I mentioned, we had originally done the trial in 6 to 12-year-olds, but really heard from pediatricians that they wanted this to be 2 to 18 years of age. They wanted it for every child they saw that would be eligible. And again, there are certain programs that have the greater than a 95th percentile, but we really wanted to do this earlier on, and we feel like the content is helpful for everyone. So we started our criteria as BMI over the 85th percentile. You can go to the next slide. So we've really done this in a whole lot of different settings. We've done it in urban and rural and suburban areas. This has all been done in a very diverse patient setting. Our first trial was done among 93% Hispanic populations, and everything is in English and Spanish. We've also done in-person and hybrid approaches. So during COVID, we were doing our dissemination and implementation trial in rural Mississippi, which doesn't even have good connectivity in their health centers. And so they were even doing phone visits and phone group visits, and really engaging people in different ways that we never imagined were possible before the pandemic. We can go to the next slide. As I mentioned, this has been kind of a labor of love over 12 years. So we first did Mass in Motion Kids, which was really piloting this concept of a healthy weight clinic in primary care. This was a whole of community intervention, which is very cool, among children 2 to 12 years of age. And this was in conjunction with our Massachusetts Department of Public Health. So this was done in Fitchburg and New Bedford, and they had multiple things going on, but our team was in charge of implementing the Healthy Weight Clinic within primary care. But they engaged childcare, elementary and middle school, after school programs, and even they had ads on buses to enroll in Mass in Motion. And then the next one is our large randomized control trial, which is the clinic and community approaches to healthy weight clinic. And this is where we got the evidence to be CDC and AAP recognized. This was an RCT, and we compared the healthy weight clinic versus the YMCA program. And we had hypothesized that they would be equally as effective in reducing BMI. And we did those in 2 cities in Massachusetts, and Holyoke and New Bedford. And this is when we started to offer the 26 contact hours, and really showed that the Healthy Weight Clinic was effective in improving BMI. And then the final thing, which we just wrapped up, and I'm writing the main manuscript now, is a type 3 hybrid effectiveness implementation trial. And so what we did is we took all our materials from the randomized control trial, worked with the American Academy of Pediatrics to really package this, and try to study if we package all these materials and we're training providers, both asynchronously and in virtual learning collaboratives, can we implement this in 8 health centers with fidelity? And I'm happy to say that we just looked at all the data, and that was proven to be so. So we can go to the next slide. So as I mentioned, we've shown that the Healthy Weight Clinic not only improved BMI, but also has improved quality of life for patients and families, and all of those three translational interventions I just talked about. It also reduced parental stress, and then binge eating symptoms is another piece that I really wanted to make sure that we weren't inducing eating disorders by doing this. And in fact, we see the exact opposite, that those pieces and symptoms get better. We've also shown it to be cost effective in clinical settings, which is a paper we did with the Choices team who were involved in the, the Healthy Weight Clinic randomized control trial. And what we found was that if national implementation was done in every health center, we would save 14.6 million in healthcare costs over 10 years. We also, because we were reaching federally qualified health centers where diverse populations are, the Choices team also found that if we implemented this nationally, it would be expected to reduce healthcare disparities. In a new paper that was just published recently, we showed also that in the pilot and the dissemination implementation trial, this can be revenue generating for federally qualified health centers and community health centers. So in fact, Holyoke Health Center, who did this, was actually making $20,000 in addition to their cost of implementing the program. And finally, it's focused on addressing unmet social needs. As Molly mentioned, I'm the Senior Health and Research Advisor at the Greater Boston Food Bank, which gets out really great nutritious foods to 600,000 people each month. And we know that you cannot make healthy lifestyle changes when your family is dealing with food insecurity or other housing or transportation needs. And so we really focus on that and make sure that these families are getting those needs met. You can go to the next slide. So now we have all the tools and resources to really disseminate this. And basically with the AAP, we've created this build your own healthy weight clinic platform. So we provide training, technical assistance, tools, and resources for really the health centers to get from the bottom of the mountain to the top in a sustaining program. We can go to the next slide. So what the unique value of the Healthy Weight Clinic to healthcare providers and organizations through our qualitative work, what we found is that we can offer treatment consistent with the AAP clinical practice guidelines right in primary care. This also allows for intensive health behavioral lifestyle treatment to be on site, which allows for avenues for advanced treatment if children need that. So often now we're seeing if people are interested in GLP-1s, they need to have been offered these IHBLTs before they are made available to them. We also have shown that you can bill for these services, and although community health workers are not reimbursable in the states we've been in, the dietitian and the pediatrician billing has made up for the cost of the community health worker. The AAP is also putting recognized Healthy Weight Clinic sites on their website. And it's also an opportunity to increase referrals to other clinical services. So some programs, our new program in New Hampshire, actually the bariatric surgery team sponsored that because they wanted more kids not to need surgery. And so they provide staffing and the space for the Healthy Weight Clinic in Southern New Hampshire to be conducted. And then pediatricians and dietitians can receive CME and CEU credits. We also have a QI program, which makes sure we're really doing the model as we intended it in the randomized control trial. We have all these staff watching these clinics and making sure everything is going well. But now we have QI modules that the AAP helps us set up so that we can do fidelity monitoring across the country. But that gives the pediatricians MOC part 2 and part 4 credits to maintain their certification. Can go to the next slide. For families, it's really one-stop shopping for everything and their healthcare needs. Right now, as I mentioned, we're doing this for children with asthma as well, and we're actually also hoping to do this with children with Down syndrome. And so it's really nice to see that this group curriculum can be really adapted and other comorbid conditions can be added on, and we can show improvements in health. It also gives access to both individual care and peer group sessions. So the teenage group sessions are really fun because they get to know each other. They're sharing each other's social media accounts, etc. And that community that can be built and really making people feel like they're not alone is really important. And then, as I mentioned, the medical management of comorbid conditions can happen too. Go to the next slide. So the Healthy Weight Clinic is now on the AAP website, and providers can log in and they get a multitude of resources so that they can do this in their community. And so this is just the opening web page that we have. We can go to the next slide. We also have about 11 hours of online training modules that they can go through. They're now much more interactive than this, but they cover weight stigma, family centered care, billing and coding, community resource guides, many different things. So if a staff member leaves, it's not all on the pediatrician to train that new member. Anyone can come on and learn about the core components of the model. You can go to the next slide. And then everyone always wants to know what the group curriculum is. Group session 1 is really on healthy foods and creating a healthy home and really making this a family-centered goal. So I always tell people that I love tortilla chips and guacamole. So if my husband came home and said these tortilla chips and guacamole are just for me and not for you, I would only be thinking about that. So really setting up the home so it's easy for the kids to make these healthy goals and for it to be everyone's goal in the family. Um, and then group session 2 is about healthy drinks and healthy plates and portion sizes. And so this is when they get to measure how much sugar is in each drink and make that. And all these have really interactive pieces in it because we heard from families that's what they wanted. They also have physical activity brain breaks too. There's also healthy plates and portion sizes. So that's talking about my plate. And then also what a portion size looks like for a child is obviously different at 4 versus a 16-year-old. In group session 3, we're really focused on behaviors and emotions around eating and mindfulness and also physical activity. Group session 4 is about bullying and teasing. We know many of these kids are experiencing weight stigma and bullying and teasing. And so we really want it to be a safe space for people to talk about those experiences and also highlight resources to help advocate for children too. I don't think a lot of families know how to navigate that. And so that often becomes a topic. And then the last part of that group is the parents telling the kids what it is really good about them, and the kids telling the parents about what they really love about their parents. So it's a really nice session, and it helps everyone. And then group session 5 is about sleep and screen time and strategies for improving those. And group session 6 is sort of this like the the I don't know, the last mile and where they've gotten, because label reading is really complicated, but they all wanted to know that. So they do that in meal patterns and snacks. It's a really fun one where you could do like scavenger hunts in the kitchen if you're doing it Zoom and find labels and compare different labels. We can go to the next slide. We give a group session facilitator guide. So many pediatricians or community health workers or dietitians have never done group visits. And so this really walks them through how this flow should go. We also have PowerPoint slides. I will say once people know the material, they want to do more interactive things. But as they get started, it can be a really nice grounding place for them. We have 20 videos in English, Spanish of the core components of these, and they're all a minute and a half. And actually, this is what our team did during lockdown. They're really amazing, and they're all in English and Spanish and could really help families if they've missed that group curriculum. And then there's always patient handouts for both individual and group visits for the clinics to use. We can go to the next slide. The community resource guide, we walk them through how to build one on their own or think about resources that might be available to them in their community as well. You can go to the next slide. And then the biggest part of this is the support and resources to implement a healthy weight clinic. So we have virtual learning sessions where the clinics come in and they share stories. And we really we've seen a lot of hiccups along the way. A lot of it is like, how do I set up a schedule? How do I bill for things. And so we've seen a lot of different models of this. So we get to share best practices throughout and solutions we found have worked for other health organizations. There are those recorded modules, and then there's tons of resources and tool exploration. So anything we built really in the randomized control trial or dissemination implementation trial or new clinics have shared with us, we have those all on the website. And then the last thing is a technical assistance. So both the American Academy of Pediatrics team who put together the clinical practice guidelines, myself, and then Dr. Vinny Biggs, who's been doing this with me for 20 years. We provide one-on-one technical assistance for any clinics who are having a lot of trouble, and we run the virtual learning collaborative. And go to the next slide. The virtual learning collaborative, as a researcher, we always are checking to make sure everything is going well. And when you scale your program to the nation, you want to make sure it's all going as smoothly as possible. And so it's been great to see how the AAP does these QI modules. They have to submit 15 notes basically, and then we can look at the core components they're making. Are they making two goals for the family? Are they offering community resources? Is there, are they addressing nutrition and physical activity? And so it's been really nice to see how those are going and making sure the model is being implemented in ways that we feel are safe and are family centered and not weight stigmatizing. We can go to the next slide. So it is a step-by-step process. We actually are providing support for these clinics for 5 years. So we know this takes a while. So we'll onboard them, build their systems, help them engage their families, refine their systems, implement the healthy weight clinic, and then really make sure that they have a successfully sustained program financially. And that's why we developed a cost tool to really show providers how many patients they need to see so that they can be sustainable in the long run. We can go to the next slide. So these are just some of the patient story quotes from the provider perspective, but you can see one of the PCPs, he had said he stuck through the group visits the whole entire time. I took the patient's advice, like ask more questions, make sure we give you answers to heart. It's nice to partner with the patient. It wasn't only what he needed and him setting the goal right, he was helping me be a better pediatrician as well, and that's fun. And so the group visits are really kind of amazing and help with burnout on the staff level too, of saying the same thing over and over and seeing these families really work together creatively. You can go to the next slide. And then these are some program feedback quotes. So the cost tool was really kind of an amazing tool that came out of the choices team had done our cost effectiveness and our second trial and our second iteration of this. And so in the third iteration, we were able to really make a practical tool, and people love having it, and it can justify keeping this program to leaders and making sure people have protected time to do this. Can go to the next slide. So after all of the research, we were able to kind of launch this through the American Academy of Pediatrics. And in January, we started this separate from any research funding. And so now we are in 6 states, and I think there will be probably 9 or 10 in the fall when we open another cohort. But you can see we're really across the country and so proud of all these clinics for continuing to implement. Can go to the next slide. So here's my email, and then that's the website for the clinical practice guidelines. And then you can go to the next slide. I think it has our QR code, and then there's also a video as well. So we'll put those in the chat. So I'd love to toss it back to Molly. I think there's one more poll question and then we can open it up. I see the chat was active, but I wasn't reading while I was doing it. So
Awesome. Thank you so much for such a great presentation, Lauren. This was awesome. I love how you walked us through kind of each of the different pieces of the program, and it was so cool to see the resources available, and just really nice to, see all the hard work really that's gone into this. So really appreciate that. I do have a poll question I'm going to put in the chat. So we're looking for folks to kind of respond via the chat, and we just kind of love to hear folks' thoughts on this. How could the Healthy Weight Clinic program be better advertised? Are there other ways that we can kind of get the word out about this? So if folks have thoughts on this, please do feel free to share. And so I do have some questions here, but I also see a couple in the chat that I want to get to first. So
okay,
thank you.
sounds good.
Yeah, thank you, Marissa. So Marissa asked a couple of questions. So will the slides be sent out? Yes, we're going to be sharing them, making them available on our website, and we'll also include them in our follow-up email. And then I think Marissa also asked the training modules, group curriculum content, and session resources, et cetera, can only be accessed by pediatricians via the AAP portal, correct? Is that correct, Lauren?
Yeah, so you can, if you're interested in doing this, you can reach out on the website or you can reach out to me and we can set up a one-on-one call to talk about how to access that. We have had psychologists successfully do this. Actually, Cambridge Health Alliance has been um, doing this with a psychologist. So it doesn't have to be a pediatrician. It could be a nurse practitioner. It could be actually a general nurse has done this too. So any pediatric provider and then the community health worker and dietitian can do it. But it is on the AAP portal only because we want to make sure that we're being family centered and non-weight stigmatizing and making sure that we understand who's implementing the program and that we're supporting them so we can keep the evidence base really strong and make sure that this continues to be effective for families.
Awesome. Thanks for explaining that. And thank you for those questions, Marissa. And folks, feel free to keep putting your questions in the chat, or you can come off mute and ask any questions. So while you're thinking about that and thinking about our question that we posed to you in the chat, I have some here already for you, Lauren. So you noted during your presentation that this program has been deployed via like in-person, but also hybrid kind of virtual approaches too. Can you just expand on that a little bit?
Yeah, so the original trial was only in person, and then obviously the pandemic disrupted this. And I mentioned we were in rural Mississippi. So we really wanted to try this in places that were different than Massachusetts. So we had two health centers agree to do it, and they were amazing. And we kind of had to roll with whatever we could do during COVID. So they ended up doing some phone group visits and some phone only individual visits as well. But we have been doing this mostly in person or via video visits. I think there's benefits to both. In fact, we're doing a trial to test in person versus online now. So we'll see, but I think some families prefer one and some families prefer the other. And it's also nice sometimes, like for the group visits in particular, I think virtual after school can be helpful so they can just log on, but we'll see how that trial comes out.
Great. Thanks for that additional
Yeah.
context. Um, so at Choices, we kind of talk a lot about implementation of strategies, but then also like who's actually paying for them. And you noted that the Healthy Weight Clinic program has not only been shown to be cost effective, but it can also be revenue generating for both federally qualified health centers and community health centers. I think that's a really big point. Could you say a little bit more about that, like how that happens, and then kind of what that means for uptake of the program in other settings?
Yeah, so I actually went with the CDC and actually six other organizations to advocate for clinical or for CPT codes for all of the family healthy weight programs. So we're unique in that we can use existing um, E&M codes, which is a CPT code, and then we can also use MNT codes, which are um, dietitian codes to get some of the program reimbursed. There are some states that do community health worker reimbursement, but it's pretty low. But we're basically using existing insurance codes to get this funded. And then the cost tool puts in, you basically put in, I need half a day of a dietitian, I need 50% of community health worker, I need 10% of a pediatrician. This is what I'm paying them. This is what I expect to get from the various insurers I have. And then it spits out the number, minimum number to be revenue neutral or revenue generating. And so for Holyoke Health Center was like 33 patients on average, and they see about 50 a year. That's on average what most of our centers are seeing. And then MGH needed to see about, so my academic medical center needed to see about 50 kids to be um, revenue generating. And then in Mississippi, where dietitians are not reimbursed, they needed to see 80. So you can see that the variability in insurance reimbursement will play an impact in how well we're able to move this forward. But as I mentioned, we've tried to get CPT codes and then HCPCS codes for all the programs. And so I am hopeful that one day we'll have them so we can really spread. But in the meantime, the Healthy Weight Clinic, because of the existing codes, can be spread.
That's awesome. Thanks for explaining that.
Yeah.
And folks, keep questions coming. So another one I have for you, Lauren. So in one of your slides, and actually there's a question that just popped up in the chat, and it's actually relevant.
Hospital.
So
Yeah.
perfect timing.
Yeah.
So it's about the cost tool. So could you say more about that, but then also how folks can
Yeah,
access?
so just contact me or contact the AAP, and if you're interested in the program, we can walk you through the cost tool. I think actually there's a screenshot in the publication, but we can walk you through that if you're interested in the program to just understand what would be the cost of this to the health center, and then the initial kind of upfront costs, and then what will it take to sustain. So you can definitely reach out to us. We can share that. We even have like I think Jeremiah, who's on my team, has created a little video so that it's not so cumbersome. But yeah, um, yeah, we've tried. So Marissa, I love this question about so Allie Goodman, who is at CDC and who's been kind of overseeing the work of the spread of the family healthy weight programs. She told me during COVID, we're going to Seattle, we're going to advocate for codes. And I'm like, okay. So we went, and then we got actually 5 or 6. So American Nutrition Dietetics, the American Academy of Family Practitioners, the American Psychological Association, AAP, CDC, we've all sponsored these codes. We've gone 3 times and it was denied. So then we went to HCPCS codes, which is through CMS, but it hasn't been heard twice actually. And we don't exactly know why that was the case. It does sound like CMS is maybe more interested in it right now and is reaching out to various people who've been involved. So I'm hopeful to do it. I think AMA has less been, there's a lot of programs, and I would encourage you to explore them. Like Building Healthy Families is a great program, but it's out of Parks and Rec. And so for them to have billing capacity, we really needed codes that could be done in the community and not just in the clinical setting. And so I think getting CMS or the AMA to kind of understand that this was needed to address the issue has been a little bit of a learning curve. So that's our biggest challenge. But before I retire, I'll make sure we have these codes. So I have a few good years left. So
Great. Thank you, Lauren. And great
yeah.
question. Yeah, keep the questions coming. These are really great. So I know there was a question submitted in advance, just kind of about disordered eating. And I know you did touch on this in your presentation a little bit, but is there any more you can add to that, Lauren?
Yeah, so We definitely have been monitoring these in all the family healthy weight programs. In fact, the family behavioral treatment program out of Wash U is Denise Wilfley, is the PI in that, and she's both an eating disorder expert and an obesity expert. And so really we've been monitoring them, and what we find is things get better. Because I think people are going on the internet, children are going on the internet and looking at fad diets or abusing laxatives according to what they're seeing online. And so these are all evidence-based programs that are going to really make sure they're eating enough and variety and safely and not losing weight too quickly. And so we've been watching that really, really closely. So that's what we find. And I think it's an important thing to keep raising and ensuring we're doing this. I would love to honestly change the name of this program from away from Healthy Weight Clinic, but it has been in existence for 12 years and was named before I really was the lead. So it's not really about the weight. It's really about taking good care of your body, sleeping well, reducing screen time, eating healthy. So which is good for all of us. So honestly, this program could be used for any family. I see there is a question about eligibility. Do you want me to read that out, Emily? Okay,
Yeah,
sounds
go
good.
for it.
Yeah, all right. So there's a question about the younger age kids and would be eligible to be enrolled. Is there a window of time that they have to be enrolled by, or is it immediate? So um, you can they can actually just keep going to the program. So I know I showed you this year-long iteration, and that's because we have 5-year grants and we have to enroll them. But truthfully, what we have in real practice, people are like, when does this child graduate? And what do you do after the year? And some families want to keep going even if the BMI is normal, because again, this is good for all of us to know, and people like the community and the teamwork. So um, as long as there is a billing code you can bill for, which you can be creative, like family history of hypercholesterolemia or at risk of malnutrition or something, then you can keep going. And yeah, I think it's still important to keep going. And also, in addition, we don't always measure their weight. We ask them, do you want your weight measured? Because this is, again, not about the weight, it's about their goals and what they want to do as a family for overall living well. Yeah, I hope that answered the question. I think these are the ones in the chat. Okay. So,
Great. Thank you. Great. Again, great question, and appreciate your response, Lauren. So I'm curious what some of the kind of common challenges are that you see when scaling up the Healthy Weight Clinic program and how they're being addressed.
yeah, so I've been actually pleasantly surprised about how this is going. We actually had to do like we had to go through our innovations office. I had to do training on how you copyright things and how you market it. And we really haven't marketed that much, and people are trickling in. So that's good. We'll see. The AAP is considering marketing it, but we wanted to do it in a way that our health centers are feeling the value of this program, the training. And so we want to do it really well. So we started with the first 5 that are outside of grant funding, and then another 5. We had enough interest, so we'll do another 5 in the fall, and it will keep growing. A lot of the institutions that are starting, they wanted to do it system wide, and we suggested starting with one clinic, and then they'll build on that too. So I think it's really great to see the interest. I think the billing will obviously make everything, unfortunately, it's always about the money and return on investment. So I think if we can push the codes and keep, sharing the cost data that Choices did with us, I think hopefully that will continue to roll out. Oh yeah, okay. I see another chat. There's a good question in the chat from Maria that we did engage community and child care centers and what that might have included. And we certainly met with them. We actually tried to change some of the nutritional content they were offering. We, talked to the WIC program officer or WIC administrators too about how we deal with the juice in the WIC package at that time. And so that's sort of how we did it. It was a big community level intervention, very hard to evaluate, honestly, except for the Healthy Weight Clinic, which was just a small part. But it was really getting everyone together to be really aligned on what our nutrition goals. How do we look at this? What are physical activity goals for those pieces too? Um, I see Don's question about the adjustments in the MyPlate information. I have heard those are forthcoming. Um, we are sort of as a team gonna evaluate what those are suggested and then whether we incorporate them for or not. Our program is based off of MyPlate, which is evidence-based and for people to easy to follow. Some of the other family healthy weight programs do the traffic light diet. We have never done that, and we've shown just MyPlate to be effective. It's easier for these families, I think, not to track green, yellow, and red foods. So
Great.
yeah,
Well,
good question, Don. We've talked about it, so we'll see.
yeah, these are great questions. Thank you, folks. And I think we're just sort of getting to the end of our time here. So I want to thank you all for your engagement and great questions. If you just stick around for another moment or two, I'll share a couple of closing notes. But thanks for all the great responses here as well, Lauren. This has been a really nice discussion. So just a reminder again, the recording, the slides, we'll be sharing those out sometime within the next week, hopefully early next week. So be on the lookout. If you registered and attended, which you all did, you'll be included on that email, but it'll also just be available on our website. So you can keep an eye there. I want to also remind folks, we do have our Choices Community of Practice portal. It's free to register, free to join. So we can pop a quick link in the chat. The link is on the slide here. But you can join, access additional resources, and you can also explore our member directory, which is a really great way to kind of connect with other people. You can search by location or topic area that folks are working on. So do feel free to take a moment and make use of that. There's going to be a little survey that'll pop up on your screen at the end of this event. We just ask you if you don't mind taking a few moments to fill that out so we can make these events better and better for all of you. And I think Lauren, thank you so much, has put her email in the chat if folks want to reach out. So that is such a great resource. So thank you for doing that, Lauren. And we hope to see you all on our next event. So thank you again, everyone, for joining. And thank you so much, Lauren, for your time and all the awesome information you shared and great responses to all the questions that came up. It's been a pleasure having you join our coffee chat.
At any time. Thanks so much for all the great questions and for the engagement, everyone. Hope you have a good day.
Thanks, everyone. Happy summer. Have a great rest of your day.